Okay, I am back. Good afternoon. If you can hear me, indicate. All right. So we're continuing with airway management. We're looking at positive pressure ventilation and why it's so important that it is done properly. So let us continue. Techniques for artificial ventilation. Carefully assess the adequacy of respiration. Explain procedure to patient. Place the mask over the patient's mouth and nose. After sealing the mask on the patient's face, squeeze bag with patient's inhalation. Now, if you have to bag a patient that is still displaying movement at the chest, even though it's poor chest rise, you have to synchronize with the patient's breathing pattern. So if that patient is breathing for the first 5 to 10 breaths, you will squeeze the BVM, bag valve mask, or breathe through the pocket mask when the patient inhales to expand their tidal volume. So CPAP, specifically CPAP, BiPAP, you're not gonna see that much in the field because BiPAP is expensive. CPAP is continuous airway pressure. So there's a pressure that's created using the device when the patient breathes in. That's CPAP. BiPAP is 2 pressures, one on inhalation, one on exhalation. And basically, CPAP is needed if you have a patient with fluid in the lungs. So anytime you have a patient with pulmonary edema and their blood pressure is not low, they don't have any chest complication or any raised intracranial pressure, then the CPAP, oxygen is given with CPAP, given under pressure to push the fluid out of the alveoli so that the exchange of oxygen and carbon dioxide can occur. Mouth to mask, you have your mouth to mask for positive pressure. You have your BVM. Mouth to mask is ideal if you cannot get someone to assist you with the BVM, or if your BVM technique is not adequate. So if your bag valve mask technique is not good enough, you can switch over to a pocket mask where you can create a double seal. A very important equipment to invest in. Patient without suspected spine injury. Anytime you're gonna be doing rescue breathing or breathing for a patient, you will always position yourself at the head of the patient. And with the mouth to mask, you're able to use two hands to create a seal. And the technique that we use is the EC technique. Right, so you're able to create a double seal. Seal on that side, seal on this side. When you're doing rescue breathing for an adult patient with a pulse, 1 breath every 5 to 6 seconds, or 1 breath every 5 seconds. If it's a pediatric patient, then it's 1 breath every 3 to 5. Now there are some books that will say 1 breath every 5 to 6 seconds for an adult, There's some books will say one breath every 3 to 5 seconds, right? Just ensure that it's not being done too fast, too forceful, and the airway is properly positioned. Bag valve mask, it's a handheld ventilation device used to ventilate non-breathing patient or patient in respiratory failure. Respiratory failure means poor chest rise, altered level of consciousness. And you have various sizes. You have your adult size, so it has a mask that goes on the patient's face. You have a bag that you squeeze, and at the end it has a oxygen reservoir, and there's a port that you can connect an oxygen tube into and connect it to an O2 tank or oxygen tank. Standard features: self-refilling shell that is easily cleaned and sterilized, non-jam valve that allows an oxygen inlet flow of 15 liters per minute. So once you're using a BVM, you're not going to give less than 15 liters per minute. And it has a non-rebreathing valve. Mechanics of the BVM: supply of 15 liters per minute of oxygen attached and enters the reservoir. When squeezed, ear inlet close and oxygen is delivered to the patient. When released, there is passive expiration by the patient. So the best way to use the BVM is 2-person. So when you start to practice with the device, if you're not comfortable with it, it's going to be awkward and difficult with 1 person. Maintain the seal and bag the patient appropriately. If it's something that you use often, then you won't have a problem. But the ideal method for BVM use is 2-person. 1 person maintains the seal, the other person squeezes the bag. But that might not be available depending on where you work and the type of protocols that you have, if you have any. All of this is practical. Right. No, definitely 2-person BVM ventilation would be preferred for your trauma patient that you suspect spinal injury. So again, you're using the EC technique. And let me see if I can see it here. No, it's not in that slide. All of this. All right. If the patient has a opening in the neck, it's a complete stoma or opening, then you ventilate through that opening. If it's a partial opening, then you may have to seal the mouth and nose, or someone will have to seal the mouth and nose, and then you ventilate through the stoma in the neck. All right, now for flow-restricted oxygen-powered ventilation device, this part of the slide or in your textbook, you can read it. It's not something I'm going to go through because you're not going to see this in EMS out here, and you're not going to see it much in the States either. It's a device basically that you put settings, set it, and then you press a button and it delivers ventilation manually. So you manually press the button and it delivers ventilations, but you have automatic ones as well, where you put the setting in for the ventilation and then put it on the patient, and it will deliver ventilation when it is needed. But you're not going to see that much in EMS. They're not cheap. You can read up on the manual one, you can read up on the ATV. That's not something I need to spend a lot of time on. I think about it. How would you decide which positive pressure delivery device you would use for your patient? So how are you going to decide if you're going to use a pocket mask, one-person BVM, two-person BVM, or CPAP? Because that's the ones that you need to really be familiar with. So with the first one, CPAP, let's go with CPAP first. What would determine if I go for CPAP? Mr. Powell. Andre Powell.
Yes, sir. The continuous positive airway pressure. I would say for a patient who has a pulse but not breathing or require rescue breathing.
Not quite. Miss Wellington, when would CPAP be necessary or considered? Miss Wellington.
Yes, sir.
When would CPAP be indicated?
CPAP could be used in the case if the patient, if you want to continually applying pressure, sir, for a patient.
Not quite. Not quite. Miss Cephas, when would CPAP be indicated? What is it used for? CPAP. Miss Cephas, present or absent?
Present, but I'm not sure his answer.
All right, moving down the line. Manning, when would CPAP be indicated?
Yes, sir. The CPAP would be indicated to action because the person cannot breathe on their own, so it will provide them with adequate oxygen continuously.
Moving up the line. That's not correct. Mr. Wilson, Patrick Wilson, when would CPAP be indicated?
Sir, so when a person is low on oxygen and they're unable to have this sufficient nutrients within their body to circulate at the time, sir?
Not correct. Michael Wilson, when does a patient require CPAP?
Sir, man, I think when a person have fluid in the lungs.
That would be correct. So when the patient has fluid in the lungs and is at risk for going into respiratory failure, but their blood pressure is not low, you can't give a patient with low pressure CPAP, but that is an indication. Pulmonary edema, especially with congestive heart failure, you might need to think about CPAP at that point. All right. Yes, Miss Cephas.
Sir, why can't you do it if you have a low pressure?
I don't hear you.
Why can't you use CPAP if they have low blood pressure?
because it's a device that is giving continuous pressure when the patient breathes in, and that is continuous positive pressure. What does continuous positive pressure do to venous return with CPAPs? It's something I explained prior to lunch. What does positive pressure do to venous return? Is CPAPs?
Sir, is that, I don't remember the term that you use, but is it where you call like wasted air? That's what I mean.
Not quite.
The air
Not
that
quite. Not quite. Mute your mic. Yes, Mr. Johnson. Go ahead.
Yes, sir. Let's say it limit the amount of you call it now, venous return to the heart.
That's correct. That's correct. So it's going to reduce the amount of blood. Mute your mic. It's going to reduce the amount of blood that is returning to the right side of the heart. So if you have a device that is continuously giving positive pressure when a patient is breathing in, if that patient already had a low blood pressure, what do you think is going to happen? Who can answer that? So the patient blood pressure is low, and you're giving them continuous positive pressure with CPAP because it's oxygen being administered under high pressure to keep the alveoli open. What is going to happen to the patient blood pressure? Patient already have a low blood pressure. What is going to happen to it now? Anybody have an answer for that? Go ahead. Go ahead.
Can't you feel no?
The what?
Hello?
Yes, go ahead.
All right. So if you induce more positive pressure while patient can breathe for themselves, right? That is the case.
Yes.
Right. So at two, say they have excess pressure, I go up the lungs, which are going to move through circulatory system. So if pressure, much pressure go in the them are where carry on the thing, them are go maybe burst.
They wouldn't burst, but I get what you're saying. They're not gonna burst. Not gonna burst. So the blood vessels are not gonna rupture.
No.
No. All right, so mute your mic. It goes back to the anatomy and physiology, right? Remember that the alveoli has capillaries over it. So there are capillaries over the alveoli, hugging the alveoli. If the pressure inside of the alveoli increases too much, then the alveoli is going to expand and it's going to compress the capillaries that are over it. Right? So those capillaries will be compressed and that will interfere or reduce the amount of blood that is flowing through the capillaries that's supposed to go back to the heart. So as I said, the patient venous return is going to be reduced. So if the patient already have a low blood pressure, it's just going to drop lower. And if the blood pressure drop too low, then you're going to have shock. You're going to have a severe shock state, which can lead to organ failure. If you ventilate too forcefully and it's a patient with chronic respiratory issues, you can rupture an alveoli. So CPAP. Now that CPAP, when would I decide if I'm going to go with a pocket mask over positive pressure ventilation via a BVM. So when would I choose a pocket mask over a BVM? Or consider using a pocket mask over a BVM? George.
Sir, you know, consider using the pocket mask over the BVM when the patient don't need positive ventilation, sir?
Not quite. Both a pocket mask and a BVM provides positive pressure. Ms. Lewis, when would I decide if I'm going to use a mouth-to-mask, pocket mask method to breathe for a patient, or I'm going to use a BVM method?
I'll pass on this one, sir.
Okay. Anybody else? Go ahead, Michael.
Well, sir, we want to reason it. The BVM would I use a patient in a complete respiratory failure. So once patient in a complete respiratory failure, then more than I think use the pocket mask.
No. Both pocket mask and BVM can be used for the same thing. When would you use the pocket mask instead of the BVM? So both of them treat the same thing for chest rise. When would it be more rational for me to use a pocket mask over a BVM? Yes, Mr. Johnson, go ahead.
Yes, sir. With the two device them, what I say, when you use the pocket mask, you alone can deal with the patient, but for, as I say, with the bag valve mask, for secure the mask part on the face and for maintain the open airway. So I saw the difference between the two of them, I think could have worked out.
All right, that makes sense. So that makes sense, that's rational. All right, so I would decide if I'm going with a pocket mask dependent on whether or not I am comfortable with my seal with a BVM, right? So if one person BVM is the only method available and I'm not comfortable with using the BVM, then I would go to the pocket mask because I can use both hands to form a seal with the mask. So it would be more appropriate. If you're bagging a patient with a BVM and you start to have difficulty with your BVM, switch over to your pocket mask. If the patient requires assisted or artificial ventilation, right, and there is nobody or your partner is occupied with something else, it might be appropriate at that point to use your pocket mask. All right. Oxygen therapy. Let's go into oxygen therapy. So, importance of supplemental oxygen. Issues to consider when making decision about oxygen administration. It is a drug, and because it is a drug, it must have an indication, right? So there must be an indication. Any patient that is showing signs of hypoxia will require oxygen. Oxygen can cause harm. So if there's too much oxygen in the body, it can cause problems. Oxygen should be administered based on your overall evaluation of the patient's presentation and possible underlying condition. Very important point. So we don't give oxygen based on numbers, right? You will not decide if the patient is going to get oxygen based on his breathing rate. Looking at everything, all of the findings. What are the findings telling me? Do I need to go high or low flow oxygen, or do I need to provide oxygen under positive pressure ventilation? So oxygen therapy equipment, you have portable, in the field, lightweight, safe, dependable. And you have your oxygen cylinder that's on the unit, and there's a picture of, this is a picture The small one would be on the stretcher. This one also be carried in the field. Then you have a large tank that is on the unit, and usually your oxygen cylinder will have this color. It can be completely green, or it has green and gray color for your smaller tanks. This is the large tank on the unit. I have various types or sizes, I should say. You have your D cylinder, E cylinder, M cylinder. The D and the Super D is very common in EMS, and the M cylinder is common in EMS. So regardless of the amount of liters of oxygen in the tank pressure when the cylinder is filled is going to be 2000 psi. Yes, Mr. Johnson.
With regard to the cylinders, sir, never really treat that type with the pressure when it's full. You don't look on it by, let's say there's a 100 pound or a 20 pound or a 30 pound or a 50 pound cylinder.
Okay, well, in EMS it is referred as PSI, and the pound is not important. The weight of the cylinder, not important. The gas, the amount of gas, the liters of oxygen that's in the cylinder, that is important. The pressure that the gas is under, that is important. That is what you need to focus on for this course, right? And I would say focus more on the pressure inside of the tank, because I'm not going to be giving maths to work out how long the pressure is going to last in the tank. It is something that may be necessary if you have to do long transport with your patient, right? So it might be important for you to know the formula, which is the tank pressure minus the residual pressure times the cylinder constant divided by the flow rate, and that will tell you how long the oxygen cylinder is going to last per minutes, right? But for this course, not going that direction. If you're going to do a advanced course or higher, then we'll have that discussion. So the Super D and the M cylinder is common. Regardless of the liters of oxygen in the tank pressure when it is filled with the oxygen is 2000 psi. The residual pressure is 200 psi. So once the tank starts to go below 500 psi, it is recommended that the tank be replaced at that point. The residual pressure is 200 psi. Now, there's no way we can give a patient 2000 psi of pressure for oxygen. So we can't give oxygen under 2000 psi. So there is an oxygen regulator that can attach to the cylinder. Right? Let me backtrack a bit. So this is the regulator. And this regulator for the small oxygen tanks uses a pin indexing system. What does that mean? So there are pins on this regulator that will line up with the pins on the cylinder stem, so that this cylinder will only be fitted to a regulator for oxygen cylinder. You can't put any other regulator on it. And what that regulator does is when it is turned on, it reduces the pressure to a lower pressure. So it's going to reduce that pressure to a lower pressure, and then you now can turn on the tank and adjust it to the desired flow rate. The larger tank on the unit uses the American indexing system, which is the same principle. The regulator has pins on it that can only be attached to that type of cylinder. All right. Now, this is going through the steps to open the cylinder tank. That's a skill. So we're not going to read through that step by step. That's something you have to watch and learn. So this is what I was saying. The regulator is going to reduce that pressure from 2000 psi to 70 psi, 40 psi, 30 psi. And you can adjust the flow rate that you want based on the device that you're using to administer oxygen. Right, now flow meters allow control of the flow of oxygen in liters per minute. Low pressure flow meters, you have the pressure compensated flow meter. We'll see that in the hospital. That's the one with the ball. Right. Constant flow selector valve. You have high pressure flow meters, thumper, CPR devices. You have respirators and ventilators such as CPAP and BiPAP devices. And remember, the CPAP is when you suspect pulmonary edema once it meets the criteria. Now, humidifiers. There are some regulators that will have a port to connect a humidifier. Right now, it is not something that is used in field practice, in pre-hospital care, emergency care, right? There are patients that may need a humidifier. So if you're going to be giving oxygen over an extended period of time, certainly you want to use the humidifier, which is that canister with water. When the oxygen flows into it, it moistens the oxygen and then the patient breathes in the oxygen, right? Because if you get dry oxygen over a long period of time, it dries out the mucous membrane and it can make it difficult for that oxygen to be absorbed into the bloodstream. Yes, Mr. Jones.
The one you mentioned without the the humidifier.
Yes.
Would it make the blood vessels or whatever oxygen a pass through, as I say, make it dry? It will cause it to get stiff based on the dryness.
I don't think so.
Okay. So what are some of the complications that could develop?
Sorry?
Humidifier.
I'm not hearing you. You're breaking up.
The patient could without the...
Use somebody else's mic. You're breaking up. I can't hear you.
Hello?
Yes.
Okay, so he was saying what are the complications that could occur without the use of a humidifier?
What are the complications that would occur without the use of the humidifier? In EMS, there are no complications. That's the answer. You got that? Yes, go ahead.
Yes, Chief. We're here.
Good. All right, so back to what I was saying. There are some regulators that uses There are some regulators that uses a humidifier. The purpose of the humidifier is if you're going to give oxygen over an extended period of time, right? If you give dry oxygen over an extended period of time, already mentioned this previously, it can dry out the mucous membrane. It can make it difficult for the oxygen to be absorbed. The time frame in which oxygen is administered to a patient in EMS will not be long enough for that to be an issue. And if you have done a proper assessment on your patient, you will be able to recognize when a humidifier is needed. This is how it works. I go in the field and I assess the patient. It's a patient that, let's say the patient has an upper respiratory tract infection, something that is going to dry out their mucous membranes, upper airway burns. This is a patient that will benefit from humidified oxygen. However, in the field, I start off with dry oxygen until the patient gets inside of the unit. Once the patient gets inside of the unit, then the patient is placed on humidified oxygen. I do not use humidified oxygen in the field unless I have to be there with the patient for an extended period of time. And that's not going to happen unless you're doing what is referred to as critical transport. Now, if, and I see this a lot, if you are going to leave the humidifier on the oxygen tank, it needs to be sealed. If it's not sealed, it's a dirty humidifier. That's one. Two, the water in the humidifier needs to be changed per patient and per shift. If you are not going to be doing that, the humidifier should not be on the oxygen cylinder. That's a dirty humidifier. And if you're giving a patient dirty oxygen, you're introducing bacteria and all type of harmful microorganisms into the patient lungs, and you're putting the patient at risk for pneumonia. If you are going to use a humidifier, the minimum level for the humidifier is acceptable. You don't want too much water in there because it can start to bubble up and get into the line and get into the patient's ear passage. So that's your humidifiers. Connected to flow meter, provide moisture to dry oxygen supply cylinder. Right, so any patient with an upper respiratory tract infection will benefit from the humidifier. Patients with airway burns, these patients will benefit from it. Right? Do not get in the practice of carrying it in the field. If it's on the oxygen cylinder in the field, the cylinder has to be upright. In a chaotic environment, no matter how much you tell people watch where you step, that can be a problem, right? Don't make your job harder than it needs to be. So that's the humidifier. If you're doing extended oxygenation for your patient, then definitely you need to use the humidifier. Patient has upper respiratory tract or lower respiratory tract issues, humidifier will be beneficial to the patient. Patient with airway burns should be considered. You give dry oxygen in the field. Once the patient reaches the unit, switch over to your humidifier. That's it. Right, now, hazards of oxygen therapy. Common hazards of oxygen and oxygen equipment. If the tank is punctured or a valve breaks off, the tank pressure is significant. It can become a missile. Oxygen support the combustion process. So The flames get in, mix with the oxygen, we're gonna have issues. Right? Oxygen can cause toxicity. It can wash off the surfactant of the alveoli and cause it to collapse. It can act as free radicals. If the oxygen molecules in the blood does not have a blood cell to occupy, they become free radicals. So they move around and end up in places that they're not supposed to be. And they can damage other cells. Can damage the eyes of the infant. Right? It can suppress the respiratory system. So administering oxygen. Work with your instructor or follow your instructor's direction to understand how to use the equipment. Various devices are available. You have your non-rebreathing mask. So in EMS, we use non-rebreathing mask. We use partial rebreather. And we use the nebulizing mask. So non-rebreathing mask, partial rebreather, nebulizing mask, nasal cannula as well for low flow. Best way to deliver high concentration of oxygen to a breathing patient is going to be the non-rebreather. That's what it looks like. So the non-rebreather has two flutter valves, one on the left, one on the right. And there is a reservoir attached, reservoir bag for oxygen, right? So oxygen goes into the bag. Once it's completely filled, you put the device on the patient. Explain what is going to happen to the patient. Sir, mom, it appears that you might be having some trouble breathing. I'm going to be putting a device on your face. It's going to assist you with your breathing or help with your breathing. At any point you start to have any discomfort or you can feel like you're about to vomit, just let me know. Communicate to the patient what is going to happen. Now, with a non-rebreather, you're looking at, some books will say 10, some will say 12, some books will say 15. So anywhere between 10, 12, 15. I've also seen outside of that range where mask giving 25 liters per minute, right? So anywhere from 10 to 12 to 15 liters. What is being pushed a lot now is 12 to 15 liters per minute. Right, so the non-rebreather provides oxygen concentration of 80 to 100%. It's going to be between 80 to 90. Optimum flow rate is 12 to 15 liters per minute. A new design feature allows for one emergency port in the mask to the patient. The patient can still receive atmospheric air if the oxygen supply fails. So back in the days, it didn't have that. But they added it now, that if the oxygen run out, it doesn't suffocate the patient. Excuse me. Right now, the nasal cannula is a low flow device. And as the name suggests, it goes into the nostril. And it is anchored around the ears. That's what it looks like. All right, so it provides oxygen concentration between 24 to 44%. Oxygen is delivered to the patient by two prongs that rest in the patient's nostril. Should deliver no more than 4 to 6 liters. So the range is 1 to 6 liters per minute as a range. 1 to 6 liters per minute. When you are using a nasal cannula, if you have to go past 3 or 4 liters per minute, might as well you use a high flow device. If you have to go past 3 to 4 liters per minute, it's better you go with a high flow device at that point, because if you start to go above 4 liters with a nasal cannula, the oxygen is going to start to burn, right? It's going to be very uncomfortable if it's dry oxygen. All right, now partial rebreather. The partial rebreather, let me see if there's a picture. No picture. All right, so let me backtrack a bit. Now, the partial rebreather, it looks exactly like the non-rebreather. The difference is one of the valves is absent, right? So there is no valve. There's a valve, sorry, but you don't have valves on both sides. It's not completely sealed, so that is only oxygen the patient is getting. With the partial non-rebreather, the outside air can mix with the mask. It is still a high flow device, just like the non-rebreather. It would be ideal for your patients that, or your patient that is having a panic attack or hyperventilation syndrome. So patients that are having panic attack and hyperventilation syndrome will benefit from this mask. So in EMS, we do not use paper bags to correct panic attack. That's a no-no in EMS. That's not something that we practice, right? So what is recommended is the partial rebreather mask, and the rationale is fairly simple. If the patient is having a panic attack or hyperventilation syndrome and you're not able to determine if that is really what is happening, because what could be happening is the patient is compensating. So the patient might be compensating for a metabolic state. And if a patient is compensating for metabolic, a patient is compensating for metabolic acidosis, what is happening is the body breaks up the acid into carbon dioxide and water, and the patient breathes off the CO2. So they are going to be breathing rapid and deep. That's how they compensate. So the body compensates for metabolic acidosis using respiratory alkalosis. Now, if you are not sure if that is what is going on, and you give a patient a paper bag to breathe or rebreathe CO2, if the patient is rebreathing CO2, all that is going to transpire at that point is that CO2 is going to combine with water, form carbonic acid, and drops the pH even further. So eventually the patient is going to lose consciousness. So the ideal device would be the partial rebreather mask. Now, if you are certain that the patient is hyperventilating, don't just fling the mask on the patient's face. Have a conversation with the patient. So you recognize that the patient is having a panic attack. Hey, sir, mom, you need to control your breathing. No, I can't do it. I can't. Yes, you can. We are going to do it together. No, I can't. Yes, we can do this together. We are going to work together. Try and hold your breath for 5 seconds. Just try. Come on, try. Work with me. Go ahead. Deep breath. 5, 4. Oh, come again. We can't make it down to 1. Calm the patient down before you put the device on the patient's face. If the patient is not controlling their breathing pattern, it don't make sense. They need to have a conversation with the patient. So worst case scenario, if them can't calm down, the patient is going to lose consciousness. When they lose consciousness, go to work. Position the airway, make sure it's clear, use an adjunct if it is needed. If not, what is the lower airway assessment telling you? Do I need supplemental? Do I need positive pressure? That's how it works. So partial rebreather mask, very similar to the non-rebreather mask. No one-way valve in the opening to the reservoir delivers 40 to 60% oxygen at 9 to 10 liters per minute. Some book will say 8, right? The Venturi mask, you're not going to see this mask a lot in EMS, but maybe in the rich services. It's a mask based on the connector. It can give you different O2 rates. So it can give low, medium, high. It can give various rates based on the connector that you use for the mask. Right, tracheostomy mask placed over stomach tracheostomy tube to provide supplemental oxygen, connected to 8 to 10 liters per minute of oxygen via supplied tubing. That's what that looks like. All right, now special considerations. Facial injuries. Bleeding and swelling can disrupt movement of ear. Aggressive suction and advanced airway maneuvers may be necessary. As I stated earlier, there will be some calls in which ALS procedures is definitely warranted. Let me backtrack a bit. Okay. Obstruction. Foreign bodies can impede ventilation of the patients. If unable to ventilate, always consider the possibility of an obstruction. So if you position the airway correctly and you're ventilating correctly and you're feeling resistance, right? So you position the airway, look, listen, feel, do what you need to do. You try to ventilate, there is resistance. You reposition, you try again, still resistance. More than likely, it's possible that that patient might have an airway obstruction. Dental appliances, dentures should ordinarily be left in place during airway procedures. Partial dentures may become dislodged during an emergency. Leave a partial denture in place if possible, but be prepared to remove it if it endangers the airway. And for a pediatric population, hypoxia often occurs rapidly. Anytime a pediatric patient goes into cardiac arrest, it's going to be commonly associated with some type of respiratory problem. So if you can fix the respiratory problem, you can save them life. Children burn oxygen at twice the rate of adults, accounted for by the many anatomical differences associated with airway. Ventilating pediatric patients, avoid excessive pressure and volume. Use properly sized face masks. No restricted oxygen-powered ventilation devices contraindicated. Use pediatric-sized non-rebreather mask and nasal cannulas. Gastric distension may impair adequate ventilation. So for assisting the advanced airway, with advanced airway, I'm not going to go through this section, right? Because I don't think this group has demonstrated that it's something I need to cover at this point. But basically what this part of the section is you being familiar with the equipment that ALS providers use, right? So that if you're working with a ALS provider, they need your assistance in setting up for intubation, you know what to do and how to assist them. And this is better explained through practical procedures. So I'm not going to go through intubation. And there was one of you that put on the assignment incubation procedures. Not sure what that was about, right? And I am certain that I pointed out to you guys when you're answering the question, answer it based on what is done in EMS at that level. So I don't know how incubation procedures come into DNR situation, but it is what it is at this point. If you can't follow simple instructions, there's going to be consequences. So we will, if you guys are receptive and learn quickly, then I'll go through the familiarization process with the advanced airway equipment. Might even throw in King LT in it as well. If you're not receptive and learn quickly, then we can't go down that road. We need to know basic before we can discuss advanced. Right, that's a must. All right, now chapter review. Respiratory failure is the result of inadequate breathing that is insufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilation. Oxygen can be delivered to the non-rebreathing patient, as a supplement to artificial ventilation. Oxygen can also be administered as therapy to the breathing patient whose breathing is inadequate or who is cyanotic, cool, and clammy, short of breath, suffering chest pain, suffering severe injuries, or displaying an altered mental status. Remember, always use proper personal protective equipment when managing an airway. Assessment of breathing must be an ongoing process. Respiratory status can change over time. Inadequate breathing requires immediate action. Positive pressure ventilations are very different than normal breathing and can have negative side effects. Select the most appropriate method of positive pressure ventilation based upon the needs of the individual. Always use appropriate safety measures when handling oxygen. Select the appropriate delivery device to provide supplemental oxygen. Questions to consider. What are the signs of respiratory distress? These are questions that you must be able to answer. What are the signs of respiratory failure? For BVM ventilations, what are the recommended variations in technique for 1 or 2 rescuers? These are things we will have to master. How does the way positive pressure ventilation moves ear differs from how the body normally moves ear? Things that we need to be familiar with. Describe a patient problem that would benefit from administration of oxygen and explain how to decide what oxygen delivery device should be used. So there's a lot that you need to think about. I'm not gonna throw these questions out there as yet. I think you need a little more time with the material before we can start thinking that deep. But these questions will have to be answered at some point. Now, critical thinking. Let's see what they have for critical thinking. On arrival at the emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale, slightly blue, pale and slightly blue around her lips. On arrival, you have an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale, slightly blue around her lips. All right, so before I throw this critical thinking question out here. All right, okay. Is this patient in respiratory failure? And if so, what signs and symptoms indicate this? Does this patient require artificial ventilation? So who wants to take that question? Is this patient in respiratory failure? Does the patient require artificial ventilation? And it would actually be assisted ventilation. Yes, Ms. Cephas.
So let me give it a try. Okay, so I would say that enough oxygen isn't going to her blood. So yes, I would give her artificial ventilation.
Answer the first question first, Ms. Cephas. Is the patient
Can you put this? Can you put the slide on the question, please?
Can I do what?
Put the slide on the question.
The slide is on the question. Oh, I get what you're saying.
Thank you.
Is the patient in respiratory failure? And if so, what signs and symptoms indicate this?
All right, so I'm saying enough oxygen isn't going to her blood because of her discoloration, because she's a little blue around the lips. So I would think there's a problem with her blood flow, her blood pressure, I guess. And that's a symptom that indicates respiratory failure. But she isn't wheezing or anything. She's unconscious. So
You're grabbing for straws. You're grabbing for straws, Miss Cephas. You know what that means?
no, sir.
Mean you're throwing things out there until something sticks. The question is very straightforward. Very straightforward. The patient is semi-conscious, breathing at 7 breaths per minute. 7 breaths per minute. With pale and slightly, so the patient is pale and slightly blue around the lips. Question is very straightforward. Is the patient in respiratory failure? Yes. Why? And if the patient is in respiratory failure, what is your management going to be? It's a straightforward question. Yes, Mr. Money, go ahead.
Sir, so to answer the first question first, which is this patient in respiratory failure, I would say yes. And second one, sorry about the background there, the truck is passing. Second one that says what signs shows this would be the discoloration of her skin, which is around the lips, and the fact that her breath is 7 breaths per minute. That's incredibly low, as you can tell by the rise and fall of the chest.
Okay.
Right, and then the last one, does this patient require artificial ventilation? I would say yes.
What was that? Yes?
Yes, sir.
How will you provide assisted ventilation for this patient?
Go again, sir.
How would you provide assisted ventilation for the patient?
In this case, I would either go, depending if I'm by myself, I would go with a pocket mask, or if, well, I'm gonna have my team, so I would go with the BVM.
You'll always be working with someone if you're working in an EMS system.
Okay,
So
well,
when
in
you
that
step by yourself, what exactly do you mean?
well, I guess I was sort of wrong there, because when I said by myself, I'm thinking I'm just the only one on the scene.
That's not supposed to happen if you're working in an EMS system.
Okay.
So it's either your partner is occupied doing something and cannot assist you at the head.
All right, so in that case, yeah.
All right. All right. Anybody else? Yes, Miss Cephas.
I'm just asking if in a case like this you still have to check with the oral, I can't pronounce the word, the oral
Pharyngeal airway.
pharyngeal airway. Would in a case like that where the patient is almost unconscious, don't you still have to check your airway? But you still have to check like her mouth to see if it's because of any blockages, or maybe you still have to listen to her breathing to see if it's something like that that stop her breathing.
All right, you're still grabbing for straws.
I'm asking you if you would, if that would still be protocol.
All right, so where's the, am I back on the question? Look at the scenario. You arrive on a scene at an emergency, sorry, on arrival at the emergency scene, you find an adult female patient who is semi-conscious. So if you guys have not learned anything from the lectures I have done today, learn this. I'm going to say it slowly. When you are going to think about managing a patient, there must be a sequential approach. You must follow a sequence. So anytime you're going to consider how to manage a patient, you must have a sequential approach to what you are doing. Now, it is clear that this patient's level of consciousness was assessed. That is clear because the presentation says that the patient is semi-conscious. So you must start at brain function, LOC. So if you're going to be considering vital signs, sorry, not vital signs. If you're going to be considering signs and symptoms, that must be the first thing that you're looking at. What is the patient's level of consciousness? The patient is semi-conscious. Is that good or bad for this patient? That's my next question. The patient is semi-conscious, right? So you have approached a patient, sir, sorry, mom, can you hear me? No response. You don't get any response, you apply pain, the patient groans. That's a semi-conscious patient. You have determined that your patient is semi-conscious. What would be the next step based on the semi-conscious finding? Anybody have any idea? Yes, Mr. Wilson.
So next one I look on ventilation.
Can be ventilation next. Why? Why? Why?
Can be ventilation.
What is the patient's brain status?
Semi-conscious.
What controls, hold on, what controls breathing?
The brainstem.
Good. So if the patient is semi-conscious, it means that the brain is not properly perfused. If a patient is semi-conscious, can that patient effectively protect their upper airway?
Awesome.
Good. So the next step must be positioning. The next step has to be positioning. You have to position the patient's airway to make sure that it is properly open. Then the next phase would be, is the patient breathing? If the patient is breathing, you evaluate the breathing. What is the rate? What is the depth? Sorry, what is the rate, rhythm, rate, rhythm, quality, and depth? That's next. Then based on that upper and lower airway assessment, then you decide what is your part. So the first thing is you assess the patient's level of consciousness. The patient is semi-conscious. Position the airway using either head tilt chin lift or jaw thrust. Make sure that the airway is clear when you position it. Look, listen, and feel. If chest rise is present, what is the rate, rhythm, quality, and depth? Based on that assessment, your patient is breathing at 7 breaths per minute. That is slow. If this patient is breathing slow, would you expect the patient to have adequate chest rise? Do you want to answer that? Yes, Mr. Wilson. Would you expect this patient to have adequate chest rise if they're breathing at 7 breaths per minute?
No, sir.
Good. So now you are able, you have the picture now. This is the picture. Patient is semi-conscious. You position the airway. When you position the airway, this is what you're seeing with the breathing. Where is the problem? That's a question that you now need to answer. Does this patient have a ventilation problem, oxygenation problem, or respiration problem? And for this patient, it is clear that the patient would have a ventilation problem, right? The patient is showing signs of respiratory failure. The only way to correct that is to assist the patient's ventilation. So there in EMS, we don't randomly do things. Nothing is random in EMS. And any branch of emergency medicine, whether it's EMS or I go work in a hospital as a doctor or nurse, there is a set approach that they use to assess your patients in an emergency situation. And the approach that the ER physician uses is almost identical to what EMS responders do. It's just that their assessment might add a few more things to it. It's A, B, C, D, E, and some other letters, right? So it's similar. You must have a sequence. Now, it can't just be SWAT what you're doing, and that's why we don't SWAT in EMS. There's no swatting when it comes to skills. That's why I spent 1 week, one entire week of going through anatomy and physiology. That was the purpose of that, to give you a base. Once you have your anatomy and physiology base, when you have the patient in front of you, I've said this before, you should be thinking about pathophysiology. That is how your patient present. And whatever you are going to do in your sequential approach, there is a reason for it. So there's a reason why I am assessing the patient's level of consciousness first. There's a reason why I am positioning the airway. You must know the reason behind what you are doing. If you can't do that, you will not be able to handle a critical emergency that requires you to think under pressure. Right? So, as I said, if you have not learned anything from the 2 lectures that I've done this week, ensure that you learn this. There is a sequence, right? Now, in EMS, regardless of what is wrong with your patient, and I would say outside of EMS, a patient has, let me see, I would say about 6, might be 6 or less than 6 intuition. Whether it's a trauma patient, whether it's a medical patient, it's 6 ways the patient can present, might be less, right? So your patient can be conscious, so the patient can be responsive with good chest rise. You can have a patient that is responsive with good chest rise. You can have a patient that is semi-responsive with good chest rise, or semi-responsive with poor chest rise. That's 3. So 1 is responsive, good chest rise. 2, Semi-responsive, good chest rise. Semi-responsive, poor chest rise. So that's 3. Right? Your patient can be unresponsive with good chest rise, unresponsive with poor chest rise, unresponsive with no chest rise. These are the ways that a patient can present, whether they have medical or traumatic emergencies. You must have a sequence to assess all of these patients. So you must know how you're going to assess a patient that's communicating with you, their chest rise is good. A patient that is not communicating, meaning the patient is semi-responsive, but they have good chest rise, or semi-responsive with poor chest rise. And it's the same thing for unresponsive. The patient can be unresponsive, but they have good chest rise. It can be unresponsive with poor chest rise, which would be failure. And they can be unresponsive with no chest rise. So sequence, if you have a sequence, a set pattern, a way to approach your patient, then you don't have to be trying to figure out all the time, what do I do next for this patient? What do I do? Am I supposed to be doing this? You don't have time for that in an emergency setting. It's not going to work. Right? So start thinking that way. Sequential approach. That's where we're going. All right. Now, based off of what I've observed today, I think I may have to present this chapter again. Right? I think I may have to present this chapter again based off of what I've observed so far. It's quite possible that I may have to do over this chapter before the week end. We'll see how it goes. Right? Because the exam for it, I think, is the following week. But we'll see how that works out. Right, now, that's the end of that chapter.